Good afternoon and welcome everyone to the fourth and final session of the Learning Collaborative on care coordination models for older adults with multiple chronic conditions, specifically diabetes. We will be exploring coordinating specialty referrals for older adults and diabetes with comorbid conditions, specifically dental and behavioral health. So as I said today, we will be looking specifically at dental and mental in our fourth session. And our objectives for today are to understand the importance of referrals to dental and behavioral services among older adults with diabetes, and to learn about and share models of referral systems to dental care and behavioral services. So to start off, I just want to go back to a slide that we've probably seen before on the number of Medicare beneficiaries receiving services or treatment for multiple chronic conditions. This is specifically for adults 65 and older, and this is from 2012. And you'll note that a good proportion of Medicare beneficiaries have more than one chronic condition that has to be managed by a health professional. And almost 25% have between 4 and 5 chronic conditions. And so, as I said, this session will focus on older adults who have diabetes, but also other comorbid conditions, either involving oral health or behavioral health. Most people believe that memory decline is a normal part of aging, but this can be a myth. Memory tends to slow with age like other functions, but decline in the ability to remember is not universal. The truth is that most of us do not experience cognitive impairment as we age. We often experience cognitive slowing. So as people age, there are detectable changes in the brain. Its weight declines by 10% by age 80, blood flow diminishes, nerve conduction slows, and nerves experience cell death. Cognitive abilities can decline gradually with these changes, but overall they do not tend to affect function or activities of daily living, and therefore deficits in cognitive decline are not a part of the normal aging process, and it's important to understand and recognize the difference. Most people believe that memory decline is a normal part of aging, but the decline in the ability to remember things is really not a normal part of the aging process, and it takes us longer to retrieve the information that we're looking for, and the same can be true for learning new information. While we could acquire information relatively quickly and retain it well when we were younger, it does take a little bit more effort to process, store, and retrieve information as we age. This loss deficit model of aging assumes that mental health problems, for example, depression, as well as cognitive decline, are normal parts of the aging process. And as we said, memory tends to slow with age, but for most adults, they do not experience cognitive impairment. Additionally, they do not experience mental health illness as the normal aging process. And the same loss deficit model of aging can also be applied to oral health, in that as people age, they expect to have declining oral health status, but we know that this does not need to happen, that the normal process is that is not that they have poor oral health. We also know that diabetes is commonly found with geriatric syndromes, that there's a high prevalence of geriatric syndromes within the diabetic population. The geriatric syndrome or geriatric syndromes are multifactorial health conditions that occur when the accumulated effects on multiple systems render an old person vulnerable to situation changes. And this can include depression and cognitive impairment and dementia. And it's important for this reason to screen for mental health issues. Geriatric symptoms are major obstacles for treatment and care of diabetic older adults. I think I just heard somebody kind of came on the line, so welcome to the fourth and final learning collaborative for the care coordination models for elders with diabetes and chronic conditions. And today the focus is on comorbid chronic conditions, specifically oral health and behavioral health. And we're just talking about the co-occurrence with diabetes and geriatric syndrome. And if you're able to access the slide deck, diabetes and geriatric syndromes, there's a high prevalence of geriatric syndromes with the diabetes population. In addressing physical and behavioral health, we know that untreated or undertreated mental illnesses have serious consequences. People with severe mental illness often die approximately 13 to 30 years earlier than the general population from medical conditions that could have been treated by a primary care provider. And people with common physical conditions also have higher rates of mental health issues, that there's a co-occurrence. The prevalence and incidence of depressive symptoms are greater in diabetic individuals than in non-diabetic individuals. And approximately 30% of people with diabetes have depressive symptoms, while 5 to 10% have major depression. The interaction between depression and diabetes in older people is found to have a synergistic effect on adverse outcomes. That is, depression predicted increased mortality, greater incidences of macro and micro complications, and disabilities in activities of daily living among older diabetics. And this can present in different patterns. So, for example, they both can occur as independent conditions with no connections. Diabetes can be complicated by the emergence of mental health illness, and specific mental health disorders increase the risk of developing diabetes. Hypoglycemic and ketoacidosis episodes present with psychiatric symptoms, and diabetes can result as a side effect of psychiatric medication. So when we think about diabetes and depression, the link between diabetes and depression, research shows that having diabetes more than doubles the risk of developing depression. And living with a chronic condition like diabetes, coping with biological and hormonal factors, plus needing to manage the condition on a daily basis may increase the risk of depression. We also know that depression can increase the likelihood of developing diabetes complications. people with depression may find it harder to deal with everyday tasks. Over time, managing diabetes, for example, regular blood glucose testing, taking medication, following a healthy eating plan, and a regular physical activity can take its toll. And this may increase a person's risk of depression, which may in turn lead to their usual or routine diabetes care being neglected. Depression is like any other illness in that that it can be treated and there are treatment options. And treatment can lift the depression and improve diabetes control. And so if people have diabetes, with better treatment control, they can potentially decrease the risk of getting depression. And if they have depression, good diabetes management may help lessen the negative impacts it can have. And depression is no different than any other complication of diabetes in that it's important for patients to seek help and support from health professionals. The treatment for depression and diabetes involves a coordinated approach that monitors both diabetes control and the symptoms of depression, and it's about finding the treatment that works best for each person. So, for example, someone with diabetes and mild depression may find that regular physical activity improves depressed moods and also helps to control blood glucose levels. And the most effective treatments often combine both medical care as well as psychological care. And so being able to talk to the primary care provider about referrals for behavioral health support can be vital and can come from, and the support also can come from not only medical providers, but also diabetes educators and community groups and families. When diabetes and psychiatric conditions co-occur, treatment outcomes decline through impaired quality of life, reduced patient adherence, etc. The cost of care can actually double in patients with co-occurring diabetes and mental health conditions compared with those who only have one or two illnesses. Primary care providers are often unaware of the possible co-occurrence of psychiatric conditions in their diabetic patients. In fact, around 45% of psychiatric disorders may go undiagnosed in patients treated for diabetes. And for this reason, the Social Security Act permits the Centers for Medicare and Medicaid Services, or CMS, to have permitted CMS to add coverage of additional preventive services through the National Coverage Determination process if all of the following criteria are met: reasonable and necessary for the prevention or early detection of illness or disability, recommended with a grade of A or B by the U.S. Preventive Services Task Force, and appropriate for individuals entitled to benefits under Part A or enrolled under Part B. Screening for depression in adults is recommended with a grade of B by the U.S. Preventive Services Task Force. And CMS reviewed the Preventive Services Task Force recommendations and supporting evidence for screening depression in adults preventive services, and determined that the criteria listed above was met, enabling CMS to cover these preventive services. Addressing the whole person or his or her physical and behavioral health is essential for positive health outcomes and cost-effective care. Many people may not have access to mental health care or may prefer to visit their primary health care provider. Although most primary care providers can treat mental disorders, particularly through medication, that may not be enough for some patients. Historically, it's been difficult for a primary care provider to offer effective, high-quality mental health care when working alone. And so combining mental health services and expertise with primary care can reduce costs, increase the quality of care, and be better for the patient overall. Adults are more likely to be seen in a primary care setting than within a mental health system. And so primary care providers can deliver half of the mental health care for common conditions such as anxiety, ADHD, depression, behavioral problems, and substance use. Yet people with mental illnesses who are treated in a primary care setting are less likely to receive effective behavioral health care. It's reported that approximately 75% of adult patients with depression would likely seek primary care providers, but only half may be accurately diagnosed. And so when a referral is made to a mental health provider, only about half the patients follow through with making an appointment. And as a result, many behavioral health problems can go undetected, undertreated, or untreated. So now switching gears to diabetes and oral health, there's been growing evidence that demonstrates the relationship between systemic diseases and oral health, with the premise that periodontal disease and other systemic diseases have a bidirectional interaction. Previous studies suggest a strong correlation between periodontitis and type 2 diabetes, and that diabetes is a well-known risk factor for periodontal disease. Additionally, evidence of periodontal diseases impact on glycemic control of diabetic patients, and the triangular relationship between periodontal disease, diabetes, and obesity has been cited. On average, patients with periodontitis showed higher glycated hemoglobin compared with individuals without periodontitis. And among subjects or among patients with severe periodontitis whose metabolic status was unknown, approximately 18% of suspected new diabetes cases were identified. The implications is that a dental office that treats patients with periodontitis may be a suitable location for screening for diabetes by a simple finger stick and validated A1C dry spot analysis. Whether caring for natural teeth or dentures, daily oral hygiene can mean that older individuals or older adults will be free of oral pain, maintain a well-balanced diet, and enjoy interpersonal relationships and a positive self-image. Without practicing good oral health, advancing age may put older adults at risk for a number of oral health problems, including nutrition issues, problems with nutrition, as well as problems with their quality of life. Oral health problems in older adults make it more difficult for them to consume a healthy diet, and physical factors directly affecting nutrition include changes in chewing ability, dry mouth, which is often a common side effect of a lot of medications, untreated tooth decay, loose or missing teeth, dentures, particularly ill-fitting dentures or implants, as well as I think I had mentioned ill-fitting dentures and bridges. Regular oral health care can improve and prevent oral problems. So when we think about coordinated care with diabetic patients, or coordinated care in terms of chronic comorbid conditions, and particularly between diabetic patients who have the need for behavioral and oral health care, we can think of different levels of care, and this has been looked at in behavioral health, levels of integrated care in behavioral health in primary care, and it also is relatable to oral health as well. And so one of the levels that we have is coordinated care, where the focus really is on communication. And so primary care and behavioral or oral health providers communicate about shared patients, but maintain separate facilities and systems. The second level of care now going up is co-located care. And that's where the focus is on physical proximity of providers. Behavioral and oral health and primary care providers are located, are in a co-located practice, and they may share the same facility, but not necessarily the same practice space. They may be co-adjacent. The third level of care is integrated care, and that's where there's a real practice change focus. And this is where providers can jointly plan and execute goals, develop integrated care plans, co-manage patients, and maintain shared schedules. So when we think about the collaborative care model, we can think of 3 steps overall: screening, counseling, and referring. And in terms of the screening, what primary care providers can do is they may screen using several tools. So for example, their diabetic patients could be screened for behavioral health issues, particularly among the older adult population. The geriatric depression scale can be used if providers are concerned about the cognitive status of their patients. They might use the mini mental status exam, as well as if there are other issues that the provider wants to screen for, they might use something like the PHQ, the Patient Health Questionnaire. And so, as I had mentioned, the collaborative care model, the 3 steps from screening, counseling to referring, the primary goal of care coordination is pushing out or being involved in a high-quality referral or transition. A referral occurs when a patient requires additional specialized care by a medical consultant or community agency, and a transition is when a patient's overall care is being transferred between institutions, such as from the hospital back to primary care. One of the primary goals of, as I said, one of the primary goals of care coordination is the high quality referral or transition. So what constitutes high quality? And so you can think of high quality in that all patient referrals and transitions should meet the 6 Institute of Medicine or IOM aims of high quality health care. And so from this perspective, referrals and transitions, sorry, I want to say transmissions, referrals and transitions should be timely. Patients receive needed transitions and consultative services without unnecessary delays. They are safe in that referrals and transitions are planned and managed to prevent harm to patients from medical or administrative errors. They're effective in that the referrals and transitions are based on scientific knowledge and executed well to maximize their benefits. They are patient-centered in that they are responsive to patient and family needs and preferences. They are also efficient. Referrals and transitions are limited to those that are likely to benefit patients and avoid unnecessary duplication of services. And lastly, they are equitable in that the availability and quality of referrals and transitions does not vary by the personal characteristics of the patient. Sorry about that, backing up. So you can ask the question, when should you refer patients to mental or behavioral health? And this is from an article from Greenberg, The Psychological Impact of Acute and Chronic Illness, a Practical Guide for Primary Care Physicians. And this outlines some of the times to refer patients to mental or behavioral health. Referrals should be made when a screening is positive for a mental or behavioral health issue. And so again, what was mentioned previously within the older adult population, if a primary care provider either suspects or routinely gives their patients the geriatric depression scale. If the screening, if the depression scale is positive for depression, that would be a time that they would refer their patient. Additionally, if the patient requires more support with health behavior change, they might be referred to a behavioral health specialist to manage their medication adherence or changing of behavior to focus specifically on some health behavior changes or medication compliance that might be problematic for them. Additionally, they can be referred when they require help adjusting to multiple acute or chronic health conditions. It may be that if they were newly diagnosed with another chronic health condition, that they may need some assistance in helping them to frame how they are going to manage, particularly if it's managing compliance or behavior around this new condition. Additionally, another time to refer is when there are several psychosocial issues. For example, if there's multiple somatic complaints without a physical cause. And lastly, patients should be referred when there's onboarding issues with new psychiatric medication. So if a primary care provider discovers that a patient who had just received a new psychiatric medication and is having some effects of that medication, that they should then be referred back to their health behavior specialist in order to address that the side effects of the medication. If we think about coordinated care, we had discussed previously an older adult case. It was a case study in coordinated care. It was a woman who was older. She had decade-plus type 2 diabetes, high blood pressure, major depression episodes, as well as issues with weight struggles over the years, and she had visited her PCP and had described symptoms of fatigue, some depressive symptoms, elevated A1C, as well as elevated blood pressure. She had, the primary care provider had her complete the PHQ, and she was positive for depression. And the PCP had, who had previously engaged with a mental health center, had agreed to refer to one mental health provider who had access to, where they both had access to an e-referral system. And so the mental health referral was actually well coordinated because the primary care provider insisted that that the patient make the appointment with the assistance of a referral coordinator before leaving the health center. And even though the patient had missed the appointment, the e-referral system noted the missed appointment, and the referral coordinator called her to reschedule. And so at the mental health visit, the mental health provider had the patient's clinical information available to her, and the provider was able to adjust her depression meds, but had also noted that she continued to have an elevated blood pressure, and that the patient had additional complaints as well. And so the mental health provider was then able to arrange for her to be seen by her PCP later in the day. And that allowed for the PCP to adjust her blood pressure meds. And so at home, the referral coordinator was able to follow up with the patient and actually had suggested bringing in a neighborhood resource, that is EMTs at the neighborhood fire station, where they could check the patient's blood pressure every other day. And so the patient had complied with seeing the EMTs every other day, was able to keep her blood pressure in the target level, and actually had reported feeling depressed. And so this is a good case. This is a good, I should say, a good illustration of coordinated care where the PCP had already developed a good referral system for getting the a patient who had screened positively for depression into a mental health provider, behavioral health provider, who was also able then to note physical issues and had referred back to the PCP. So we can also ask the question, as we did with behavioral health, when do we refer patients to behavioral health? When do we refer patients to oral health? Similarly to behavioral health, we would refer patients who screen positive for oral health disease or changes in oral health status. We would refer patients who require more support with oral health-related health behavior change. And we'd also refer patients who require help adjusting to multiple acute or chronic health conditions or medications that may impact oral health. So in this next slide, this is an article from the American Dental Association Health Policy Institute, and from 2016, and the title is Physicians Dissatisfied with Current Referral Process to Dentists. And this was in a tertiary healthcare setting. Physicians reported they were dissatisfied with the referral system to dentists, the coverage of dental care services for patients, and their ability to distinguish a worrisome oral lesion from a variant of normal. And that more than half of the worrisome lesions were referred to physician specialists instead of dentists, specifically due to the lack of a referral system. And that the efforts to improve the referral system to dentists facilitate the creation of an electronic referral system and promote dental education for physicians, who could increase both physician and dentist satisfaction and the quality and efficiency of care for patients. And so similarly to the coordinated care illustration, a good referral system, particularly an electronic referral system where both providers have access to the same information, can help make a referral a much better experience for both the providers and the patients. There's actually been some work done through the National Network of Oral Health Access in terms of referrals and managing a good referral policy. There's also another source that is very helpful, and this is a white paper on oral health, an essential component of primary care implementation guide. And within this implementation guide is a section on structuring referrals to dentistry. This white paper is supported by Qualis Health and as well as several other groups, including the National Interprofessional Initiative on Oral Health. And so again, it has some very helpful guidelines, implementation guidelines for structuring referrals to dentistry. In terms of the structured referral to dentistry, information that the dentist needs to participate in the patient's care are a variety of things, including the problem list, current medication, allergies, reason for referral, and particularly if this patient requires treatment, a statement about the patient's health related to the ability to undergo treatment. The structured referral also includes a notification that the patient was scheduled, including the date and time, and a summary of findings and treatment plan that is returned to the referring provider. So essentially to close the loop on the information that that the dentist had decided in terms of what they found, as well as the course of treatment is sent back to the referring patient, or excuse me, referring provider. And so there are components of an effective referral process, and components include referral agreements, so that there's an agreement between either the providers or the health agencies. There is logistical support. In the illustrative example with the patient with diabetes and depression, as well as some of the other comorbid conditions of high blood pressure. The logistical support was having a referral coordinator that helped to manage some of the nitty-gritty in terms of making the referral call to the mental health provider. Another component is connectivity, so particularly is there an e-referral or is there electronic communication? And then lastly, that an effective referral process has referral tracking and coordination, so that it's understood whether or not the patient made it to the appointment, what information was was collected, what was the course of action, and then also informing the referring provider. Well, this was outlined for a referral to oral health services. It is also it's also appropriate as an effective referral process for behavioral health services as well. So we just wanted to, in our remaining time, wanted to open up our discussion to you in how you manage referrals to either behavioral health services for your older adults with diabetes, as well as how you manage referrals to dental services for your older adults with diabetes. If you utilize a level of care coordination, what level of coordination do you use?
Hi, so we have behavioral health in the office. Dental is located at a different site, so we're at the basic collaboration level, moving towards more integrated. We consider both of those in-house referrals, so we try, there is an opportunity to do warm handoffs directly with behavioral health if they're in the office.
Mm-hmm.
For patients who need more services, there's the community mental health organizations. Those patients, I mean, I think with mental health it is, people have to present for care and intake, so a lot of that is incumbent upon the patient if they're needing more, like a higher level of services. And so for dental, we usually just tell them to make an appointment. More for our outside referrals, we're following the process you outlined with the referral being entered into the EHR with tracking and following up with patients.
Mm-hmm.
So, yeah.
Okay. Is this Paula?
Yes, yes.
Oh, hi. So welcome. So in terms of the tracking that you're doing within your EHR, is that something at your health center that you had put in a specific module for? Is that with your EHR? Is that just something that was there? Did you have to do any adjustments to it?
So it's part of our module as far as I know, so that's what we use, and we do have a referral coordinator, so all referrals are assigned to most of them, to our referral coordinator, and so she tracks them and assists patients who may need help scheduling appointments. So some of our older patients are, I find, like to have someone helping them. Yes, but that's built into our HR, but we're able to update it as new specialists are added. That can all be updated. We use eClinicalWorks as our HR.
Okay.
And then all notes are returned. Their systems don't really talk to the other specialty care offices, so in terms of information, it's all sent usually via fax between the primary care office and the specialty care office.
Oh, okay. And then that gets manually entered into your system as a closing of the loop?
Yes. So it's all faxes come in as an electronic fax, so they're assigned to the referring clinician who then reviews it. Yes. Or sometimes our referral coordinator will go through and if we haven't received a note, call the patient to see if they went to their appointment. And if they did not go or we can't contact them, she reaches out. She'll send a letter, phone calls, and if we're not able to reach the patient, then a note goes back to the clinician through the EHR that, we're not able to contact this patient to follow up. And then the clinician can either close the note or try to reach out again to the patient. So that's the loop closing.
That's great. That's great. So have you always had a referral coordinator in place in the more recent years, I guess?
Yeah, I would say within the past the past 2 years. We've
Okay.
had okay, less than a year. We were sharing for a while we were sharing a referral coordinator with some of our other sites, but now we have a full-time dedicated referral coordinator who's working with about, I don't know, 7 or 8 clinicians. He's pretty busy.
Have you noticed, anecdotally, have you noticed any difference in terms of whether or not your patients are getting the specialist care that they need, or in a timely manner, as well as getting information back?
Oh, definitely. I mean, we have a large uninsured population, so yes, so definitely I think we've had better success, and some patients who need a lot of specialty care like to call our referral coordinator and update her so the patients know. I think that patients who are more engaged in their health care will sometimes even reach out directly to our referral coordinator. So no, it's been a huge help, especially as some insurances require prior authorizations or not in network, or people are having to complete financial aid applications to go to university-based hospitals for care. It's very, I think it's very complex.
And so your referral coordinator, so it sounds like your referral coordinator is also managing that aspect of the care as well, in terms of if a patient needs a pre-authorization, kind of walking through that process with them. And
our nurse will do more of like, well, we don't really get a lot of prior auths, but for example, if the insurance, if I give a patient a referral and they're not in network, she'll help navigate the patient, to a different office.
Okay. Okay. And did I hear you say that the referral coordinator tends to work a lot more with your older adult patients?
I would say no. I mean, we have pediatrics and children. So some of our older patients will have Medicare, but I said we have a large uninsured population. Most of the pediatric patients do have insurance, but every now and then we have some that don't have insurance. So I would say it's mainly adults. The older patients do tend to prefer, I think, to have help, someone scheduling their appointments for them, kind of walking them through the process, or patients, I guess, with lower literacy levels. I think most people do appreciate having someone to kind of make the appointment for them and coordinate getting all the records over. So, yeah.
Have you noticed with the referral coordinator, or I should say, have you been tracking compliance with, or I guess compliance with attendance?
She does check that. So in terms of who, I'm not sure if she reports that to our medical director. So I don't track it. I think we have 3 main primary care sites, each with a referral coordinator, and so they have a system for going through and following up with patients to see if they went and if we've gotten the consult note, and then is closing out referrals for people we're not able to contact to see if they went for an appointment.
Fantastic. So with respect to some of the screening, do you know, and I guess this is more geared toward to the older adult population, are patients screened for depression or other conditions, depression, oral health disease, things that they might have to be referred out for specialty care?
So we, as a clinic, we screen least every 12 months patients using the PHQ-2 for depression.
Mm-hmm.
And so we also use that. We have a form we ask them to fill out that, as a social screening about, safety at home and cigarette, alcohol, drug use, their sexual behaviors. So it's like a social intake form. So that's done at least once a year. And we have our behavioral health coordinator and our behavioral health therapist. We'll look at our provider list ahead of time and make a note of who needs, we call it the orange form, who needs that screening done. And then that's communicated to our medical assistants, and they do track that regularly, like how many people needed a form, who got a form. That's about once a month by our behavioral health coordinator.
Okay. And do you have something similar to for oral health, or in that they, because you said you're co-located?
We're not for dental at our particular site.
That's right. You said, okay,
yeah,
I got it reversed. You said behavioral health is co-located, that you have behavioral health within your site, and then oral health is not at your site.
Right now at our site, it is co-located at another site. So they're the pediatricians, for example, for the children that need the oral fluoride screening. They can refer them directly there.
Okay.
But for dental, I think it's a little less, it's less formal, I would say, than our depression screening.
Okay. But that's a really interesting system that it sounds like your coordinator every month flags who needs to have the screening tools, the screening forms as part of their visit, and then works with the medical assistants to ensure that those forms are filled out at the individual's visit.
Right. She looks at them weekly, our list weekly, and then reports back to the providers and our medical director, the compliance, who needed screening and who got the screening.
And then who got it. Okay. Wow, that's really good. So it sounds like then it's patients, if they screen positive, then I was going to say quickly. I don't know if that's the correct term, but
right. We know at the time of the visit.
At the visit, and that and then with the referral coordinator in place as well. So that sounds like a really excellent system.
I was wondering if you had have you come across any good recommendations for outpatient treatment of depression within the primary care setting? Or anything that you recommend?
No, but we can find out. And so outpatient
or ambulatory care depression guidelines.
Yeah.
In the primary care setting. Because I think, as you mentioned, a lot of times it calls to the primary care provider to manage the depression and the other illnesses as well. And it seems like the diabetes guidelines we have those. We have the ADA and a number of different guidelines, but I think depression is not quite as formulaic. But I was wondering if you found anything that you thought was a good resource for the primary care practices. So there's the one
The one from, it's a little bit older, the one I had mentioned from Greenberg, and that was geared to primary care providers, and I'm trying to find the specific, I can, we can, because we have your email, I think, we could send you that
Okay.
as at least one particular resource, and then I can we can also see if there's some newer ones as well.
Great.
But that's excuse me. And it's the psychological impact of acute and chronic illness. Excuse me. But I can send you that.
Okay, thank you.
Okay. Well, thank you so much for participating. I'm sorry, I think I'm going to cough soon. Cough a lot. It was great having you involved, and thank you for sharing what you're doing at your health center. And it sounds like you're doing some really interesting things, particularly around your behavioral health integration with your primary care provider by utilizing a behavioral health coordinator as well as having a referral coordinator. So thank you so much, and I'm realizing that that we're past the hour that we said we were going to be, and so again, just wanted to thank you for participating, and Paula, I'll send you the Greenberg article as well as any others that I find that I think might be helpful for you and your primary care providers.
Great, thank you so much.
Great, thank you. Have a good rest of the summer.
Okay, you too.
Okay, thank you. Bye-bye.